Hello, everyone. My name is Laz Boris, and I'm the president of the Thyroid Foundation of Canada. I'd like to welcome you all to our October 26th webinar. Today, we have a panel of 3 thyroid patients who became hypothyroid as a result of thyroid cancer, Hashimoto's, and Graves' disease, who will describe their personal journey and how they adapted to these changes. On our panel, we have Kim McNally, Laurie Martin, and Joanne Koski. Our guest speaker is Dr. Ranjit Singarayer. He is a community endocrinologist in London, Ontario. He completed his endocrinology training in Western University. He served as chief endocrine resident and was the recipient of the Dr. Merrill Edmonds Outstanding Resident Award. He completed a 1-year clinical thyroid fellowship at the University of Toronto. He has a strong clinical and personal interest in thyroid disease, both benign and malignant. I'd like to welcome Dr. Singarayer to our webinar. After each patient's story, Dr. Singarayer will address highlights of their condition. Once all the panelists have completed their stories, the audience will be able to direct questions to either Dr. Singarayer or our panelists. Catherine Keane, our administrator, will be acting as producer for this webinar. This means she will be managing the technical aspects of Zoom. Monica Babick, our Director of Volunteer Recruitment and Development, will be looking after the Q&A function. This event will be recorded and made available on our website later this week. A little bit of housekeeping before we begin. Today we're using the webinar functionality of Zoom. This means you can see and hear the presenter and support team, but your audio and camera are not active and we're not using the raised hand feature. You'll be able to communicate with other attendees using the chat feature at the bottom of the screen. So please feel free to join in. If you do not wish to see the chat previews displayed at the bottom of your screen during the presentation, please click on the chat button arrow and deselect the Show Chat Previews option. Please use only the Q&A feature located at the bottom of your screen for your questions. If you have any technical issues during the webinar, please reach out to Catherine via the chat feature. We are now ready to begin with stories from our panelists. We'll begin with Ms. Kim McNally.
Wonderful. Thanks, Laz, and welcome everybody. So my name is Kim McNally, and my thyroid story is actually a thyroid cancer story. So in 1981, at the age of 15, I was diagnosed with, I think it was mixed papillary follicular thyroid cancer. I didn't know what a thyroid was back then, so it was very all new to me. I just followed the advice of my doctors, my parents, etc. I had surgery for that, and then I went on levothyroxine, and I was told I would take it for the rest of my life, which I have been. And then the hypothyroid didn't really become an issue until the ensuing years when I started having whole body scans. If there was a suspicious nodule in my lung, they would put me into a state of hypothyroid to have this radioactive scan. And then unfortunately, my cancer did metastasize to my lungs, and that was found in 1995. So then at that point, I was going under radioactive iodine treatment. So every time I'd have a treatment, again, I would go off my medication and go into a very severe state of hypothyroid. So I never really felt the ill effects of a thyroid condition until that time. And when I was first diagnosed, there was no internet. I couldn't Google anything. I really was like navigating it on my own. But by the time 1995 had come around, I had joined the foundation. I had wonderful information provided by the manuals, by the general meetings. I met a thyroid doctor by that time, Dr. Robert Volpe. Some people might remember him. So I had a lot more information. And I also was able to join some support groups, and we would refer to hypothyroid as hypo hell because it was excruciating. And I had the typical symptoms, the muscle weakness, I felt like my eyes were really tight or my face was swollen. I couldn't lift my arms. I was very, very tired. So I came to appreciate very quickly what the thyroid does in our body and the importance of being on the proper medication. And over the years, I've had to have my medications tweaked. So now I'm on alternating levothyroxine and Synthroid. So I take 0.125 3 days a week. I take 0.15 the other days of the week. And I'm still monitored by my endocrinologist here in Kingston and seem to be doing fine. So that is my story. And if that's all you need, Laz, I'm happy to answer any questions.
Thank you very much, Kim. I'd like to um, um, hear from Dr. Sanger and his comments on this particular case.
Yeah, thanks for sharing that, Kim. That was very powerful. Especially being diagnosed so young, 15 years, you were probably in grade 9 or 10. So, you know, early stages of high school and trying to figure things out yourself. And then, being told about this diagnosis, you probably, like you said, didn't even know what the thyroid was. So you followed the advice from your parents and your treating team. And it's interesting because I think you were so young that some patients will say that they feel different straight away. Some people feel exactly the same after they've had total thyroidectomy. Um, but it's interesting that you mentioned that you only felt thyroid hell when you had to essentially the thyroid hormone withdrawal for your scans and then for radioactive iodine treatment. It's interesting because the recombinant human TSH, so the pituitary gland makes TSH, which is the thyroid stimulating hormone, which then sends signals to the thyroid to make thyroid hormone, so T4 predominantly, and then T3 as well. So the whole point of thyroid hormone withdrawal in people who are undergoing further imaging and treatment is that the brain sends signals to any remaining thyroid cells, and then those cells then become kind of more active. So thyroid hormone withdrawal was very common and it still is used, but I think it was the late 90s, early 2000, recombinant human TSH, known as Thyrogen, became available. Um, so nowadays, when patients need to undergo thyroid hormone withdrawal to prevent them from going from what Kim described as thyroid hell, they're given a shot, 1 or 2 shots of recombinant human TSH, which is fairly costly. So that becomes an issue in terms of coverage. So a lot of people don't have private coverage. It is a few $1,000s, I think. So that prevents patients from having to withdraw from their thyroid hormone for 3 to 4 weeks prior to these tests or radioactive iodine ablation to prevent them from going through what Kim described as thyroid hell. Um, but yeah, so I suppose you would have been what, early 20s, mid 20s then when you were having to undergo further treatment and going through
Yeah,
fairly significant symptoms, which would have been hard to navigate through.
yeah.
Um, but like you said, now that you're on a stable dose, things
Mhm.
are pretty smooth sailing. Um, but the recombinant human TSH, since it became available in the late 90s, early 2000s, it's been a game changer in limiting those symptoms that patients typically go through with thyroid hormone withdrawal.
Mhm.
So, I mean,
Mhm.
if you were diagnosed in 2000 and then you needed treatment and whatnot in 2010, then you may not have gone through those episodes of severe symptoms, but
Mhm.
it is what it is, and you went through it, and you're you're doing well now. So thank you for sharing your story.
Awesome. Thank you very much. Thank you.
Thank you very much, Dr. Singer. And now we'll move on to Lori and her story.
Thank you, Laz. My name is Lori Martin, and in 2010, I was diagnosed with Hashimoto's and hypothyroid. I was probably about 48 years old when that happened, but my path to that was not easy. I can go back to when I was about 16, 17 years old, and I would have, I don't know how to totally describe it, but it was like low-grade flus that would last a long time, achy joints. I've always been the person that needs 2 or sometimes 3 alarms across the room to get out of bed. At that time, I don't need to do that anymore. But through that time, I would go to doctors and say something's not right. And I was raised that you really look up to doctors. So there was nothing wrong. Then when I had my children, my last child, I felt terrible. I couldn't move. I just wanted to cry all the time. My throat, my ears, everything, my bones, I just couldn't, I felt awful. And I was told by my family doctor that I had postpartum thyroiditis, that it was very common. Don't worry about it. And at that time, I was also the same as Kim. I had no idea what a thyroid does, never heard of it, don't know what we're doing, but my doctor said, don't worry about it. So I did not. And I was never, ever the same after that. There was no, you know, before that time, I would have parts where I didn't feel so great and then I'd be fine. But after my third baby, that was the end. I could barely get out of bed, my joints, I was in pain, gained gain weight easily. The whole, all the symptoms. But every time I'd go to the doctor, nothing wrong. Nope, it's nothing wrong. And then when my youngest, I ended up moving to a larger city and for a couple of years to go finish my schooling, which I was so sick. I shocked I did, got graduated. I had a doctor. I went to him and said, like something's not right. I'm dizzy. I'm, anxious, etc., etc. And he said to me, you're probably depressed. And I said, I don't think so. And he rolled his eyes at me. And once that happened, now I look back, well, what was I going to do anyway? Once that happened, I sort of told myself, zip your lips, don't tell anybody, and don't bring this up because I must be off my rocker and I just don't know it. So I didn't say anything and I didn't attend any doctors for the longest time. Ended up moving to a very small town. And one time, it was when I was 48, I was in my living room and I thought I had a massive heart attack. Everything stopped. I couldn't lift an arm. I couldn't lift a leg. I didn't know how to get to the couch. It was like my whole body just shut down. So yes, went to my family doctor that I didn't go to see very much. And everything was tested. I had nothing wrong with me. I don't have diabetes, don't have high cholesterol. It was my thyroid. It just totally stopped. So I was so grateful that somebody actually told me what was wrong, so it wasn't in my head. But then, of course, we had a while getting where I would feel better because I had said to my family doctor, to be quite honest, I don't even know what normal is. So I also take Synthroid, but at first it was, well, you're in range, so everything's good, but I'm going, no, I'm not good. So over time, my family doctor promised me, he said, I will make it, that you are okay. We'll do everything we can. And so it turned out that just as long as I keep my free T4 at the highest it can go in the range, that I feel pretty good. Now I ended up getting probable small fiber neuropathy also from being left so long. So I do take some medication for that, and it works great. I'm not in pain, no neuropathic pain anymore. And my synthroid, just as long as it is high up, I can get it. I don't need an alarm clock anymore. You know, and I can look after what's around me, etc. So I'm very, very grateful that my family doctor took the time that to help me. So I'm always grateful for him. I tell him that. So, and I really hope that things have changed enough, because hypo hell is not an enjoyable place to be. And I hope that things will change a little bit more, that people, you know, don't have to go through what I did, because it, in a way, even though I, you know, I have a great husband, I got great kids, I got my grandchild that I love dearly. And I'm traveling, everything's great, but I sometimes look back and man, that was a mess. So, but I'm good now, so I'm very grateful. And the Thyroid Foundation, actually, I've learned so much from even them when I first started, that, you know, it just really helped me, and helping to others that understood what I was going through. So that is my story.
Thank you very much, Lori. I'd like to pass it on to Dr. Singarayer, please, for comments.
Thanks for sharing that with us, Lori. That was also very powerful. And it's very unfortunate that you were told, like, don't worry about this. And then even, your doctor just rolling his eyes at you, and then that leading to you not seeking medical care for a long time, and then leading to a state where you were, sounds like, profoundly hypothyroid. So that's very unfortunate. And I'm glad that you finally got to like the end where you're feeling well now, which is, very important. Um, but in terms of postpartum thyroiditis, it is common, and it is mediated through antibodies. So the antibodies that often cause Hashimoto's thyroiditis are involved in postpartum thyroiditis. So the numbers in terms of how many patients with postpartum thyroiditis develop long-term hypothyroidism outside of that first postpartum year are anywhere from 20 to 50%. So, you were told it's nothing to worry about, when in fact, maybe your family doctor was just taking into account that you're postpartum and didn't want to worry you, but it probably was something to tell you that you should worry about it, because then when you developed all these symptoms, it would have made you seek medical care sooner. Because it's almost as high as 1 in 2 patients can develop overt permanent hypothyroidism outside of that first postpartum year, and it can happen decades later. Um, so, being told that it was unfortunate, but it is sometimes something that can develop and be a chronic issue. And then, like Kim had mentioned, the thyroid hell, and it sounds like you went through a long chronic period where you were feeling like that, not just the 3 to 4 weeks of thyroid hormone withdrawal, but it sounds like it was many years of that. And it comes down to a lot of the thyroid symptoms are often non-specific. So if somebody goes to their family doctor or to a medical practitioner and says, I'm feeling tired, I'm really achy, there's a lot of things that it could be. Obviously, thyroid being one of probably a list of 100. So that's where, when your GP mentioned, I will look into this and figure out what's causing your symptoms, that was very reassuring that they were willing to explore, however many causes, medical conditions there are that were causing your symptoms, and they finally got to it. And then I think the third thing that I found interesting was that you mentioned you feel much better when your free T4 is the upper limit of normal. Um, so I always tell my patients that everybody is different. Some patients will feel normal when their TSH is right in the middle of normal or the upper limit of normal, whereas other patients feel better when their TSH is at the lower end of normal. So the TSH is the thermostat, so to speak. So when the thyroid hormone levels, the T4 and the T3 are higher, the TSH typically will be lower. If either of those are high, the T4 or T3, the TSH will become low and abnormally low or suppressed. And then on the other side, if the thyroid hormones, the T4 or T3 are low, the TSH, the thermostat starts working hard and becomes elevated. So usually the TSH is the most sensitive and specific marker for thyroid function, thyroid disease, because minor variations in the T4 or T3 are usually reflected in the TSH changing. So a lot of times if you go to your family doctor and you're on levothyroxine and your TSH is normal, um, but you're just not feeling great, usually it goes back to, okay, what are other causes that should be looked into? And so when your family doctor, looked into that was kind of a different story because you still weren't diagnosed, but looking into other causes. So I always tell my patients if they're still not feeling great, their TSH is normal, it's good to get checked for other things. So that's where the family doctor comes into play, where they'll, check your blood count, make sure there's not an anemia, your iron is fine, your vitamin D. There are lots of causes for, so to speak, non-specific symptoms. And once those have been explored, then it comes back to the patient. And if, like you said, Laura, you felt better when your T4 is higher, then sometimes it's worthwhile just making minor tweaks in the dose of the levothyroxine and Synthroid to see if people may feel better. Because ultimately, as a physician or GP, endocrinologist, we're here to make our patients feel better. So if you're not feeling great and your T4 is low, or sorry, the T4 is in the mid range and everything else has been explored, then it's worthwhile to try to see if bumping up the dose very incrementally can make you feel better. And I know that probably not a lot of physicians will employ that approach, but it's worthwhile as patients to go forward to your doctor and ask, can we look at other causes? And if they've been explored and they're eliminated, then trying to optimize the thyroid hormone levels, like what we're done with Lori. So thanks for sharing your story.
Thank you very much, Dr. Singarayer. And now we'll move to our third panelist, Joanne Koski.
Thanks so much, Laz. So this is the first time that I have ever shared my story of living with now hypothyroidism caused by having Graves' disease. So I hope you will indulge me. It's funny. I work with in the work that I do, I help people who are living with various diseases, conditions to share their stories, to learn how to tell them in an effective way for advocacy or disease awareness. But as I said, this is the first time that I've been asked to do this. And so a little bit nervous, but thank you for giving me the chance to do this, because I feel like we all are helping others, by sharing our experiences. And when I do work with people to develop their stories, I always suggest that they read them out, because we all spend a lot of time thinking about this and finding, the right parts to share. So if you don't mind, I am going to read what I prepared for this discussion. So my journey started with anxiety. I was never an anxious person. And it was a time in my life when I was dealing with a lot. I had a busy career. I had a husband with a busy career, two young kids who were also super busy with school and after school programs. I mean, we were fortunate to have a nanny, but still it's a lot of running around, and you're trying to, do the best you can on all fronts. So, a fairly high stress time in my life. But I thought I was handling it. I thought I had it all under control. It was all good, except one day when I was driving home on the highway in rush hour traffic after a client meeting. I was talking to my nanny. I was like, I'm coming, don't, please, if you can stay for a few more minutes. It was just all a lot. I actually had to pull off the highway, because if I had kept driving, I think I would have crashed my car, probably hurt somebody else. And I was having like a massive anxiety attack. It was just like terrifying. And I realized at that moment that there's like something wrong. Like this is not me. And if it was me, that's fine. But, it just didn't seem like me at that moment. I was like shaky, and I was just, I just didn't feel right. So My husband came to get me, and then we had to get the car. Anyway, it was a whole thing. A few weeks later, the same thing happened again while I was driving to work. This time I was on like a regular city street. So I pulled over and I called my family doctor, and I was like, okay, I think I need to come in and see you because there's something up. So I went in, she was amazing. Right away, she was like, okay, blood work, we're going to do it all. We're going to look for things. And I think she had a feeling, what was going on at that time. So I got my blood work back, and it showed that my thyroid was like in super overdrive. And at the time, my doctor said, so you've got something called hyperthyroidism. And I'm like, okay, I have no idea what that is because I'd only heard of hypothyroidism. My mom had it at the time. And, a lot of women her age had it, hypo, but this was something new and it wasn't what she had. So my family doctor told me that there were a few things that could be happening that could be causing my thyroid to behave the way it was, and that we needed to find out quickly what was the cause because then we would know what to do about it because I couldn't go on the way I was. I was like almost, not functioning at that point. So that's when I got really scared because, as we all do, we start to comb the internet and try and figure out, okay, what could be happening to me? And that was probably a bad idea because I got, lots of different information and possible causes and then about various treatments for all the different things it could be. None of them seemed very fun. Most of them involved ultimately possibly disabling my thyroid. And I discovered at the time, as I think we all did, that, hey, this thyroid's pretty important. Plays a really important role in our body. It does lots of amazing things. And I wasn't too keen on, the option of rendering it useless, but that seemed to be something that I was going to have to contemplate. So that's when I first met my endocrinologist, and he has literally become the most important healthcare professional in my life. He is amazing, very patient with me all the time, and yeah, he's just fantastic. So he reviewed all the possible causes of a hyperactive thyroid with me. Upon physical examination, he ruled out a few he thought were unlikely. And then he sent me for some more tests. So I had a high contrast, I think, CT at the time. There was a few things. It's hard to remember. Honestly, it was a blur. It was also, he said, unlikely that I had thyroid cancer, but, just hearing that it could be that, or one of the autoimmune diseases that we've, been talking about, it was just all really scary. And I tried hard not to spiral further by reading, more stuff online about, what my future could hold, but it was really hard not to do that. I'm sure you can all relate. I think we all have been through it. And then the day that I finally got my diagnosis of Graves' disease, it was really difficult. I mean, I work in a lot of different disease areas. I'd never heard of this. And the days following were also really difficult. And I'll tell you right now, my first mistake was I went to the doctor's appointment with the endocrinologist when I got my diagnosis by myself. Because I figured, you know what, I can handle this, it'll be fine. I'll deal with it. Whatever comes my way, I can handle it. Was just definitely the wrong thing to do. And I always tell people, take people with you. You can't do this on your own because you're going to be in shock and you're not going to remember anything that anybody tells you. And even if you think you can handle it, you probably won't be able to, and that's okay. So take people with you. Anyway, my endocrinologist gave me a bunch of different pieces of paper with lots of information that I needed to make, at that point, some really important treatment decisions about how to deal with the Graves' disease, and in particular, the hyperactive thyroid that I was dealing with. So some of the things, that were happening to me or could happen to me, were out of my control. Like, for example, I learned about thyroid eye disease, that's a possibility with Graves'. And for that, I would just have to, watch and wait, as they say, to see what was going to happen. But anyway, the theme of this, I guess, story is it was all incredibly overwhelming, and I did feel very alone. I wanted to know more. I wanted to know, what other people had gone through, how they came to decisions they made about treatment, but I didn't know anybody that I could really talk to. And I didn't have the presence of mind at the time to reach out to people who I knew could support me, like the Thyroid Foundation. I just couldn't. I was just in a zone where, I just knew I had to make some decisions, and that's what I did. So I turned to my mom because she'd been dealing with hypoactive thyroidism for many years, and she helped me weigh the pros and cons of all the options that were in front of me. And so and thankfully I had options, thankfully. And so, that is one of the most important things for all of us, is that we need choices. We need different ways of treating diseases to find the one that works best for us. And so, in this case, I did. So in the beginning, though, when I first was diagnosed with hyperactive thyroid, I didn't have a choice about treatment. They had to get it under control and fast. And so I went on a couple of different treatments because I had, this anxiety, I had crazy heart palpitations at all times of the day, other symptoms, shaky, and you name it, there was a bunch of stuff going on. So those treatments really helped. I mean, one of them was like a beta blocker, if I'm not mistaken, and there was another drug. But some of the side effects of some of those treatments, one in particular, really concerned me. And I understood that I would have to be on these drugs for the long term. So I looked at another approach, and I initially had ruled out because it seemed really aggressive and final, and that was radioactive iodine therapy. So making the decision to undergo RAI was almost more upsetting and stressful than the diagnosis itself, because you're basically deliberately destroying this integral part of your body, which seemed extremely counterintuitive. But I couldn't help thinking, how is my body going to react to not having a functional thyroid? Was I going to respond to the treatment for hypothyroidism that I would be left with? And, there was some, research about RAI triggering thyroid eye disease, and that worried me as well. So lots of stuff, going on. But the one thing that made it easier to go ahead with the RAI was knowing that the standard of care for hypothyroidism, Synthroid, levothyroxine, had been around for years. It was well studied, it was safe and effective, and it had minimal side effects. And so ultimately, I decided that living with a condition that was very common and treated by a therapy that could be easily dose adjusted, which is something that remains very important to me in my disease management of hypoactive thyroid. And I'm hearing others saying the same thing. For me, that was much better than the alternative. So, I made that decision. And, for many of even with Synthroid, hypothyroidism isn't all fun and games. There are still symptoms to deal with, like weight gain and heart palpitations I still get at night, dry skin, brittle nails, restless legs, you name it. There's still stuff going on. But generally speaking, I have been very well controlled. Hormone fluctuations also, because of, being on the pill, the birth control pill, which I really had to stop, going through menopause, caused some more, fluctuations that had to be addressed. But for the last few years, my hypothyroidism has really been mostly very well controlled, with little need for dose adjustment of the Synthroid. But as soon as I start to feel a little off, my endocrinologist is like, okay, Monday and Friday, you're going to be taking this dose, Tuesday, Wednesday, Thursday, you're going to be taking this dose, that kind of thing. And it really works. So I have evaded thyroid eye disease thus far, but, I still worry about it. It's still a concern, and that's obviously because of the Graves' disease. And, some of those fears are irrational, but you know what? We have them, and that's okay. And I've never been able to shake the feeling of anxiety that I got from driving on the highway. At the very beginning, it just stays with me, even though I am sure I would be fine. I have driven on the highway a few times, since then, but it's just one of those residual things that I just, it's hard. So usually I forget that I have Graves' disease and that I don't have a functioning thyroid and everything that could mean to my health. But I do worry that one day I may need an alternative to Synthroid. And I hope that if that day comes, there will be something else for me and that I will be able to access it. So at the end of the day, you really never stop worrying. But I do feel very fortunate to be where I am today in my journey. And I am so grateful for all the care and support along the way, and to organizations like the Thyroid Foundation of Canada for being there for all of us in the work that you do. Thank you.
Thank you very much, Joanne. I now pass it on to Dr. Sangarayer.
Thanks, Joanne. That was very insightful, and I actually learned a lot from you from sharing your experience, so thank you. But yeah, it sounds very frightening that, you were driving on the highway and felt so overwhelmed with anxiety that you had to, pull over, and that's the second instance is what propelled you to go see your family doctor. And in your case, it sounds like your family doctor was very reassuring to you, and your experience was much different than Lori's experience. When she was told, don't worry, and then she didn't seek medical care for a while. And it sounds like your diagnosis was very quick. But when you mentioned that you went to see your endocrinologist, you went alone, and that was like the first mistake that you made. A lot of times when people are hyperthyroid, they had inattention, issues with concentrating, and we often find that overwhelming patients and telling them too much at their first appointment, if they're there alone, is often not a great thing, because they're likely not going to take everything in, and it's a lot to take in. So it's important to say that all your symptoms are related to the thyroid, and we'll figure out what the cause is. I typically find that after a few weeks of being on anti-thyroid medication, people's levels, once they come down, their mind's much clearer. They're able to process things better, and then usually have, by that time, more information and investigations results come in where we're able to pinpoint what it truly is, where we can have those discussions about, yeah, this is Graves' disease, or this is a toxic nodule or toxic multinodular goiter, and here is your disease kind of prognosis, the progression, the chances of going into remission. With Graves' disease, they can be as high as like 50 to 60%, but it's usually treatment with anti-thyroid meds for 12 to 18 months. And I hear you that some of the side effects, or the risks, which they're still quite rare, they can be life-threatening. So, I'm assuming you were probably worried about the risks of the white blood cells or the liver dysfunction. They're rare. Like, touch wood, I've been in practice for almost 10 years. I've never seen any, but they can happen, and they are life-threatening. And so for you, that was kind of your main precipitant to then decide that you want to have something definitive. And everybody is different in terms of what makes them want to have definitive treatment. Some people don't want to have ongoing, like monthly, every 2 months blood work to monitor their thyroid function, and be on an anti-thyroid medication where there's the risk that their levels might become low or they might become high. So some people just want to have definitive treatment, based on that. But yeah, the definitive treatments are there to lead you to that end state where you're hypothyroid, where, like you mentioned, and I'm really glad that you mentioned that, you felt reassured because there was an effective treatment in levothyroxine, which is really well, in controlling the thyroid hormone levels, and it's very, really easily dose adjusted. So I think that's very important that you mentioned that, because it highlights the importance of ongoing monitoring of the thyroid function. Even though it's a lifelong medication, we don't just put people on the meds and say, you're done, don't worry about this. The levels need to be checked routinely. Usually once a year is probably sufficient once things are stable. But if people feel unwell and have non-specific symptoms, it's always good to have the thyroid levels checked sooner, just to make sure that that's eliminated. And if it's not, then like you said, Joanne, the dose can be easily adjusted. And then in women, I think I saw a few of the questions about kind of menopause and um, estrogen replacement. That's another time period when I tell women that their levels should be checked more routinely, is when they go through menopause, because the thyroid levels do um, change based on the lack of estrogen going through menopause. Women often need a dose reduction. But it goes back to your point. It's very well treated and it's easily dose adjusted as long as the levels are monitored. So, unfortunately, it does sometimes come down to the patient. You have to be the one to say, okay, I don't feel right. I need to go to see my doctor. I need to make sure I get my thyroid levels checked, and if that's normal, then making sure it's not something else. But I think you really touched on an important point that it's very easily dose adjusted. So thanks for sharing that, and your story was very insightful.
Thank you very much, Dr. Singarayer. I think we'll now move to the second part of our presentation here, which is the Q&A. So Monica will now read the audience's questions for Dr. Singarayer or the panelists. Please remember, use only the Q&A feature located at the bottom of your screen for your questions. We will not respond to questions from the chat feature or from emails. Monica?
Okay, thank you so much, everyone, for sharing your stories too. Really, I feel like we have so much in common in hearing all these stories. And our first question is for Dr. Singarayer. Will transdermal estrogen impact women who take a replacement dose of levothyroxine?
Yeah, so it comes down to what I just talked about just with Joanne's story there. So if a woman is started on estrogen, it can impact their thyroid levels. It could make their levels a bit lower depending on where they are in their menopause journey. And then when women go through menopause, they often need a dose reduction. If they're on Synthroid, their TSH levels will usually become subnormal. So it really depends on where they are in their journey through menopause and when they go on estrogen, but oftentimes they might need an increased dose.
Thank you. And our next question is from Safia Makada. Thank you so much for sharing your story. This was for regarding Kim's story, but it was also for Dr. Singarayer. So how does treatment of thyroid cancer with radioactive iodine change the chances of spread, or is cancer spread unpredictable?
Yeah, so that really depends on the type of thyroid cancer that somebody has. So there are some more aggressive forms of thyroid cancer that can spread distally. So it really depends on what the underlying pathology is. The majority of thyroid cancers are low risk thyroid cancers called papillary thyroid cancers. They don't usually spread. And if they do spread, they usually spread locally in the neck. More aggressive thyroid cancer, which are fairly rare. Like there are more aggressive subtypes of papillary thyroid cancer, and there are some more aggressive thyroid cancers, like anaplastic thyroid cancer, which can spread more distally to the lungs. But often it's not that it's unpredictable. It's usually dependent on the underlying pathology. And usually when someone has their initial diagnosis, the doctors are able to come up with a risk stratification tool where they can stratify a patient into low risk, intermediate or moderate, and then high risk. They're usually people that are low risk. They're usually just having annual imaging, blood work done. People who are high risk typically go on to have radioactive iodine ablation. Unfortunately, some people need further surgeries. And then people with moderate or intermediate risk, depending on some factors, sometimes they're treated with radioactive iodine ablation. So it's not that it's unpredictable, the spread. We can usually predict it based on the initial pathology, but it's all patient dependent.
Thank you. And the next question is from Marg. Is the list of medications that can impact levothyroxine found in the product monograph for Synthroid accurate and complete?
So most product monographs are fairly accurate and up to date. The main things that people should try to abide by is not taking their medication, the levothyroxine, with food, because it can definitely impact the absorption. But in terms of medication, antacids, calcium containing supplements, iron supplements, sometimes antacid medication. And then there's a few very rare cholesterol meds that can impact the absorption. So those are a few medications, but usually the product monograph is fairly up to date. And the other thing I tell most of my patients is try to avoid taking the levothyroxine with hot drinks like coffee or tea, because the hot drink itself can degrade the actual thyroid hormone. So taking it with water is usually the best.
Thank you. And the next question is from Deb. Deb is wondering if it's true that levothyroxine can cause heart palpitations.
I mean, it really depends on what the patient or the person's thyroid hormone levels are. So if someone is over replaced and hyperthyroid from their levothyroxine, then certainly it can cause palpitations. But if somebody's thyroid hormone levels are in the normal range and they're not elevated on levothyroxine, they usually shouldn't have palpitations. So if somebody comes to me and says they're having, palpitations that are new, their thyroid hormone levels are normal, I usually tell them that they need to look into other cardiac causes for palpitations, because those are often need to be explored and eliminated as a potential cause.
Okay, and another question for you regarding menopause and thyroid symptoms. This one comes from Mark Shijevsky. And our symptoms are basically the same, menopause and thyroid, or similar. How can women find someone who can treat both?
Yeah, that's a good point. Yeah, they are, a lot of the times the symptoms do overlap, and thyroid symptoms can overlap with a lot of other conditions. Um, in terms of finding someone that can treat both, usually endocrinologists, it depends on what area of the country you live in, but some endocrinologists will treat both. In a lot of centers, endocrinologists will treat obviously thyroid disease, but gynecologists will treat for menopause, some postmenopausal symptoms. So that's where it becomes tricky in terms of if you're in a center where it's kind of two different specialists. It comes back to then the primary care provider being like the gatekeeper and trying to kind of synthesize everything, but it's really dependent on what center is closest to where you live, and some endocrinologists do treat both.
Thank you so much. And another question from Marg. Will both lobes of a thyroid be impacted by Graves' disease and show up on an uptake and thyroid scan?
Yeah, that's a great question. Again, typically in Graves' disease, it's autoimmune mediated. I don't think we kind of got into that with Joanne's story, but it's autoimmune mediated. So the body's made an antibody that then attacks the thyroid, and it causes the thyroid to make extra thyroid hormone. So typically both lobes, and there also is like a pyramidal lobe. Um, they usually become overactive, and it usually will light up on an uptake and scan. The times when it doesn't light up on an uptake and scan is if someone has had a recent uh, contrast. So if like a CT scan with iodine, um, or they're taking certain medications for the heart, it can sometimes lead to a false positive result, sorry, false negative result, where the scan will be normal when it truly isn't. But generally in Graves' disease, both lobes are very overactive, and it shows up on the thyroid uptake and scan, which is the gold standard test.
Another question from Sophia. So she just wanted to share, thanking Joanne for sharing her story and wondering, does the TSH thermometer analogy also apply to Graves' disease?
Yeah, so the same thing. The pituitary gland makes the TSH. So the pituitary gland is it's a gland that's located between the eyes, and it makes many endocrine precursors, one of which is the thyroid stimulating hormone. So when people have Graves' disease, their T4 and or the T3, the two thyroid hormones, are elevated, and it sends signals back to the pituitary gland to tell it that the thyroid hormone levels are high. and the thermostat, the TSH, then becomes low or undetectable. So the thermostat kind of goes with all TSH or thyroid dysfunction.
Thank you. And the next question is from Tammy Hagyard-Weeb. And Tammy, this is for anyone on the panel. Tammy's wondering if anyone has interacted with hypo patients with ADHD. Sounds counterintuitive. Is there any correlation?
I'm not sure if that question was directed directly to me or to the panelists, but I don't know directly if there's a link between the two of them. But I think ADHD, I'm not sure what the prevalence is. I don't treat it in my practice, but it goes back to the thyroid symptoms a lot of the times being non-specific. But thyroid disease can accompany many other diseases. So I think based on statistics and prevalence, you might find a large proportion of patients that actually have both diseases. But I don't know the prevalence of ADHD, but I don't know if the panelists have anything to share in that regard.
No. Okay, thank you so much. So another question for you is from Sissy. It is my FTH is 12.2 and my TSH is 6. Should I be on medications or can it be controlled with diet?
So that's a great question. So it sounds like I'm assuming you don't have any symptoms. So we would classify based on your levels that as being subclinically hypothyroid. So we typically reserve treatment in people with subclinical hypothyroidism for those who have symptoms. So a lot of those symptoms we were talking about with earlier with our stories with Kim and Lori. So if you have those symptoms, yeah, there might be benefit in trying levothyroxine or thyroid hormone replacement. If you're pregnant or trying to get pregnant, or you're breastfeeding, or you have a neck goiter, swelling in your neck, your thyroid is enlarged, then we do often treat people. In the absence of any of those features, if someone has subclinical hypothyroidism, we usually monitor the levels because at some point in time, it will likely develop to overt hypothyroidism, depending on the underlying cause for the initial thyroid dysfunction. So with Lori's story, um, if the underlying issue is it seems more autoimmune related, Hashimoto's, then there's a possibility that it will develop and your level should be checked. So it depends on your symptoms. If you have a primary care provider, I'm assuming someone checked your levels, so you should probably go back to them. And if you have any symptoms, then it's worthwhile having a discussion.
Okay, thank you so much. And another question is, in the case where a patient with hypothyroid symptoms does not feel right, even though the TSH levels are in range, should the doctor test for thyroid antibodies in the blood? Is that a question for you, doctor?
Yeah, so that's it's a good question. Um, Again, it comes back to the hypothyroid symptoms oftentimes being nonspecific and could be related to a multitude of other disease conditions. So it depends on what the symptom is. Um, if the TSH is normal, someone has a lot of symptoms in keeping with hypothyroidism. There's a strong family history of hypothyroidism. If the person themselves has other autoimmune conditions like rheumatoid arthritis, lupus, then there's a high likelihood that they might develop another autoimmune condition, such as Hashimoto's. We don't routinely check antibody levels in people whose TSH levels are normal. The antibodies simply tell us that if someone has thyroid dysfunction or disease, it tells us that yes, this person, like Lori, has Hashimoto's thyroiditis. So we don't routinely check the antibodies in people whose TSH levels are normal. If you have a lot of symptoms, depending on what they are, it might be worthwhile to explore some other causes, common ones being like iron deficiency.
Thank you so much. That question was from Donna, and our next question is from Diane. Is working to lower both thyroid antibody numbers helpful to help control your hypothyroidism?
So that's a great question. I get that a lot in practice. Usually once we establish a diagnosis of Hashimoto's thyroiditis or Graves' disease based on their antibodies, Hashimoto's, we don't often recheck the antibodies. They'll always be present, and it doesn't usually guide our decisions to treat someone with thyroid hormone replacement. As Joanne mentioned, it's usually the when someone's on treatment, their dose is easily adjusted based on their TSH. So we don't adjust levothyroxine based on antibodies. Um, with Graves' disease, however, we do like to check the antibodies, which are different antibodies that stimulate the thyroid hormone to give us a better prognostication in terms of if someone is going to go in remission and if someone is pregnant or hoping to conceive. The antibodies then help guide us in terms of risk stratifying somebody as they endeavor to go through pregnancy. So we don't normally, repeat in Hashimoto's thyroiditis, repeat the antibodies to see if they've come down because they don't usually come down. They'll always be present.
Thank you so much. The next two questions are also about Hashimoto's, and the first one is from Mike, and who's wondering if there's any reason to monitor thyroid antibodies to see if anything reduces the attack on the thyroid in Hashimoto's. Is there any research or known things that can reduce antibodies?
Yeah, that's a great question. It kind of comes back to the last question. There's no reason to really monitor the antibodies in Hashimoto's. Once they're positive, they're going to be positive. Um, and then in terms of the second part, is there any research or known things that can reduce antibodies? Um, Not really in terms of Hashimoto's. There's really known medication. Simply going on levothyroxine or thyroid hormone replacement as kind of the umbrella kind of overarching theme to today's discussion is that it's the end state. So where once someone has had sort of destruction to their thyroid gland from Hashimoto's, the end state is being on levothyroxine or thyroid hormone replacement. With careful monitoring and dose adjustment, like Joanne mentioned, but there's nothing that we can really do to reduce the antibody levels.
Thank you so much. And another question, again, very similar to that. So you may have already answered parts of it. So I have Hashimoto's. Could chronic insomnia be a symptom that I need a higher dose of levothyroxine? I have no other symptoms except maybe weight gain. And this comes from Susan.
Yeah, so the sleep is complex. There's a lot of factors that impact sleep, but if you have chronic insomnia and if there's no other factors at play and it's related, if thyroid could be impacted in it, we usually come across insomnia or issues with lack of sleep or reduced need for sleep related to high thyroid levels, so hyperthyroidism. So if your insomnia isn't caused by anything else, then it might warrant you to have your levels checked to see if you actually need a dose reduction, not a dose increase.
Thank you so much. And this one is from one of the attendees who's saying that they've been diagnosed with tall cell papillary thyroid cancer with mutations of BRAF 600 and ATM genes. What would be your thoughts on where TSH and T4 levels should be?
Yeah, so thanks for sharing that. I'm hopeful that you have a treating endocrinologist or a thyroid cancer specialist that's involved in your care. But in terms of like, I don't have obviously your pathology, but the tall cell variants of papillary thyroid cancer, like we were talking about earlier, there's different risk stratification, so low, high, low, moderate, intermediate, or high. Um, Tall cell variant with mutations that you've described, typically we would initially want the TSH target to be lower, so 0.1 to 0.5, because it'd be considered more high risk. So you definitely should. I'm hoping you have an endocrinologist or a treating thyroid cancer specialist. If you don't, then I'm not sure if there's any way for that to be relayed back to Laz in the group so that you can be connected with somebody or so that you can get some more information about who you should be referred to, depending on where you are in the country. But yeah, the TSH target would at the initial stages be usually around 0.1. It depends on other factors like your actual pathology. But I definitely would recommend that you discuss this further with whoever is your treating physician.
Okay, thank you so much. And another question for you is, what is your opinion on the use of combined T4 and T3? This comes from Linda. This is to treat resistant hypothyroidism, meaning still having debilitating symptoms at normal TSH.
Yeah, so this is a common thing that we see. Um, so it comes back to ensuring there's no other cause. Once those have been eliminated, which can take some time, if you're still having those symptoms and no other cause has been identified, then um, if that's something that you'd want to explore, then that's a discussion you probably should have with your treating physician. A lot of times, this will fall under an endocrinologist. Um, but there are levothyroxine, which is synthetic T4, is the recommendation from all major guidelines. It's like Joanne mentioned, it's easily taken, administered. There's no side effects to taking it unless you're over replaced, and it's easily dose adjusted. Um, so that's the mainstay of treatment. And some people, like yourself, if other causes have been explored and you're still just not feeling great, we sometimes offer a combination of levothyroxine and T3, which is the more biologically active form of thyroid hormone, with the caveat that the biologically active form of thyroid hormone, T3, can cause more hyperthyroid symptoms, so palpitations, sweating, insomnia. So it's a fine balance. And then there are other combination forms that are available, like desiccated thyroid extract. Um, Desiccated thyroid extract contains much higher ratios of T4 to T3. So typically the thyroid makes T4 and T3 in the ratio of about 15 to 1. But desiccated thyroid extract is ground up pig or cow thyroid, and those contain much higher ratios of T4 to T3 in the range of 5 to 1. So it contains a lot more T3. So more likely to cause symptoms like palpitations, insomnia, sweating. Um, but it really depends on what the debilitating symptoms are and if other causes have been explored. But I do have a handful of patients who are on combination therapy with T4 and T3 and a handful that are on desiccated thyroid extract, and they've been on those medications for years and they're doing well. So it's worthwhile to have that discussion with your treating physician.
Thank you so much. So another question, this is just a question, how do you convince your family doctor to run all thyroid tests, not just TSH? This is another question for you. I feel like even for me, I just say to my doctor, can you please check all of this? I'm pretty fortunate because I have a family doctor, endocrinologist, and naturopath. And as you said, like all of these working for me, but is there anything else that you would suggest to patients to advocate for themselves?
Yeah, so I mean, I think I talked about this earlier. The TSH is the most sensitive and specific marker of thyroid function. So very minor fluctuations in the T4 or T3 will be reflected in the TSH. And oftentimes, very minor changes in the T4 or T3 will be more so reflected in the TSH. So it will it's such a great thermostat that it will pick up when the T4 and T3 are abnormal. So usually in hypothyroidism, the recommendation from all major thyroid associations, the American Thyroid Association is the big one that we draw guidelines and kind of our approach to hypothyroidism treatment in Canada. They recommend TSH as being the main thyroid function that's checked. We routinely check T4 and T3 in people with Graves' disease or people with thyroid cancer, so that we kind of can treat people to more strict TSH targets, like the other question that we had with that tall cell variant. So in terms of how to convince your doctor to check everything, when somebody asks me to check everything, I usually will explain it to them like that. And if we're trying to fine tune the dose, like, probably, which we kind of highlighted with Lori and Joanne, if everything's been excluded and someone's just not feeling right and they're wanting to go on desiccated thyroid extract or combination therapy, then we definitely check the T4 and T3. If we're trying to just make minor dose adjustments with the levothyroxine, we don't often do that, but that's another time when we would check it. But routinely, the recommendation is the TSH is the most sensitive and specific marker of thyroid function in hypothyroidism, and that's usually what should be checked. So I don't know what to tell you to how to convince your doctor to check both. So yeah, I apologize for that.
Thank you so much. And the next question is from Evelyn, and this part is, can the thyroid cause osteoarthritis?
No, so the thyroid shouldn't cause osteoarthritis directly. But like Lori's story, if your hypothyroidism goes untreated for decades, years, and you're not able to, you don't have the energy to mobilize, and then it leads to considerable weight gain over long periods of time, then yeah, maybe there's, could be a link with osteoarthritis, but there's no direct link between thyroid disease and osteoarthritis, which is wear and tear on the joints. But there can be a link with over replacement of thyroid hormone and things like osteoporosis, which is weakening of the bones, which can lead to increased risks of fractures or broken bones. But yeah, there's no direct link between thyroid disease and osteoarthritis.
Thank you so much. Another question from Catherine. Is there any risk in damaging the thyroid's ability to go into remission from hypothyroid to fully suppressed TSH when doing a thyroid radioactive uptake and scan? Doing a scan to confirm Graves as had positive marker just above the normal range.
Yeah, I'm just trying to understand the question. So is there any
risk in damaging the thyroid's ability to go into remission from hypothyroid with fully suppressed TSH?
So the chances of going into remission aren't impacted by having a thyroid uptake and scan. Usually prior to a thyroid uptake and scan, which is the gold standard test, it's a 2-day test where it will tell us how overactive the thyroid is and why it's overactive. So Graves' disease being one, and there's a couple of other causes that usually are explored. But typically people need to come off their anti-thyroid medication for at least 3 to 5 days. Coming off the meds for that short period of time shouldn't impact the ability to go into remission. The ability to go into remission really depends on how high, if it's Graves' disease, how high the antibody is, patient's age, the duration of treatment. So typically treating people for at least 12 to 18 months gives them a higher chance of remission. The chances of remission are like 2/3 of patients. So there is about a third of patients who won't go into remission. But coming off, that's what I'm interpreting from your question. Coming off the anti-thyroid meds for those 3 to 5 days for a diagnostic test won't impact the chances of going into remission. It could make your thyroid symptoms worse. So it's worthwhile if you're coming off anti-thyroid meds, if your treating physician thinks that they're going to be high enough, sometimes we give patients beta blockers for that week period when they're off anti-thyroid medication just to help with their symptoms.
Thank you so much.
Can we do a couple more, Monica, and then we'll...
Close it off, no problem. So we have another one. This is from Sophia. Is there any explanation for why Graves' disease patients experience symptoms even with normal levels?
Yeah, so that's a good question. I mean, it depends on what the symptoms are. Oftentimes, at the beginning stages when someone is very hyperthyroid, there can be a lag between treating and reducing their levels with antithyroid medication, which is why we often start a beta blocker to help with the symptoms. But in terms of having an explanation for why people have symptoms, so it depends on what the symptoms are. Like if they're, compressive neck symptoms, those can still be present even when the thyroid levels are normal because someone can still have a goiter. If they're eye symptoms, yes, those can be explained because they can happen irrespective of what the thyroid function is. But if it's thyroid specific symptoms and the levels being normal, it depends on what the symptoms are. But usually once the levels are normal, the palpitations, the heat intolerance, sweating, insomnia, issues with frequent bowel motions, those should all resolve. If they don't, then it comes back to looking into other potential causes for those, because those can still be present. Someone can have Graves' disease and another autoimmune condition like ulcerative colitis, Crohn's disease, rheumatoid arthritis, lupus. So it's always good to get back to the drawing board and figure out if there's anything else. And like we talked about, this is like a lifelong thing usually. So, looking at other causes, other potential medical issues that arise.
So we have time for one more question. This is from Mark. Is a combination of levothyroxine and cytomel warranted if a patient does not feel well just taking T4 medication?
Yeah, I think there was a similar question earlier. So, comes back to making sure there's nothing else at play. Once those have been explored, if someone is still not feeling great, then the only harm in taking a combination of levothyroxine and cytomel, like I talked about, was over replacement because the cytomel has a much shorter half-life than levothyroxine. And it's more biologically active, so it has a higher propensity to cause those hyperthyroid symptoms. So that would be, the main risk if someone wants to try it. And there's no risks of irregular heart rhythms that the person has or osteoporosis, then it's worthwhile to try it. And yeah, I don't think I have much more to add to that.
Great. Thank you very much, Monica, for reading out those questions. I'd like to thank our panelists and Dr. Singarayer for his commentary on the patient stories. I would also like to thank our webinar team for making this educational event a success, and I would like to thank Viatris for supporting this webinar. I'd like to mention that if you have some spare time and would like to volunteer to help others with thyroid disease virtually from home, please call us on our helpline at 1-800-267-8822 or email us at info@thyroid.ca. You can also assist us by becoming a member or making a donation by visiting our website at thyroid.ca. As you exit the session, please take a moment to complete our short survey. You'll also have an opportunity to enter your comments. This will help us improve our webinars. Our next webinar will be on thyroid artery embolization on February 22nd, 2026 with Dr. Laurent Fredette. Thyroid artery embolization is a new non-invasive procedure for patients with thyroid goiters with compressive symptoms and multinodular goiters. Registration is free and open to all. We hope that you will join us then. Thank you very much, everyone. Thank you, Dr. Singarayer. Appreciate all your help.
Have a good day, everybody.
We'll catch everyone back in February.